So you are live on YouTube.
Yeah, sure.
So should we start? Are you ready?
Yeah, ready.
Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 13H, which is the pathology of head and neck. And we are streaming live from Regional Cancer Center, Thiruvananthapuram via Kolkata. Very special topic today, HPV associated oropharyngeal carcinoma, the talk of the town. And to talk on that, we have somebody very accomplished, Dr. Anila K R. She's an MBBS, DCP, DNB Pathology from GMC Thiruvananthapuram, Kerala. Presently, she is an associate professor in the Department of Pathology at the Regional Cancer Center, Thiruvananthapuram. And she has done a DNB from GMC Thiruvananthapuram, joined the department in RCC in 2007, and presently she is there for the last 14 years. And right now she is an associate professor with special interest in surgical pathology, especially head and neck, endocrine, and also in cytopathology. She's got multiple publications in national and international peer-reviewed journals, awarded the fellowship by the Union for International Cancer Control, UICC, in 2018. She had also undergone training in head and neck cancer pathology from the famous Mayo Clinic, USA. Before I ask Madam to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Anila ma'am, please share your screen and let us start.
Yeah, at the outset, I would like to thank Dr. Nadeem and Nilam Pathology for this invitation and also for the kind introduction. So let me start sharing my screen. So is it visible now?
No, not yet. Just press present now, your entire screen. Press in the center of the thing and then press share.
Yeah, just 1 second.
Yes, now your screen is there. We can see your screen. Great. Just choose your PowerPoint. Yeah, remove the other pop-up as well. Let us first. Yeah, great. Start, ma'am. Thank you.
Okay, thank you. So today's topic is a relevant topic of today, like HPV associated oropharyngeal carcinoma. So going on to the topic, if we see head and neck pathology as such, over the past 2 decades, there has been a tremendous development in this area of pathology. And if we seriously consider the breakthrough in this area of head and neck pathology, it has been mainly in 3 areas. First is the oropharyngeal cancer, which we'll be dealing in detail today because of our knowledge about HPV associated oropharyngeal cancer, which is essentially a squamous cell carcinoma only, but a totally different entity when compared to your routine oral cavity squamous cell carcinomas. Secondly is your salivary gland neoplasms. In that area also there has been immense advancement because of our knowledge of molecular pathology of salivary gland neoplasms, which help us in diagnosis and also in targeted therapy. Third area is in sinonasal tract tumors. So it is amazing that such a small anatomical area can give rise to such a diverse variety of tumors like your nut carcinoma, the SMARCB1 deficient carcinoma, and the biphenotypic sinonasal sarcoma and so on. So to understand today's topic, we need to understand what has been the traditional approach to oral cancers or oral squamous cell carcinomas. So we were for years using this blanket terminology of oral cancer for all the squamous cell carcinomas of the different subsites of the oral cavity. So for a change to happen to this age-old concept, you have to self-consciously try to bring about changes to your understanding of the disease, your reporting pattern and so on. So because for years it has been deeply ingrained into our thought process that the oral cavity squamous cell carcinomas, whatever the subsites, it is essentially a single entity. Okay. But now we know that this HPV associated oropharyngeal squamous cell carcinomas are a totally different entity, though they are squamous cell carcinomas only. And considering that, the WHO in the 4th edition of Head and Neck Tumors have given a separate chapter dedicated to this oropharynx. So let us briefly, all of us are aware with the different subsites of the oral cavity. So you have the lip, the upper and lower lips, the upper and lower alveolar ridges, the hard palate, the soft palate, the retromolar trigon, the floor of mouth, the tonsils, the uvula, the buccal mucosa, and of course our tongue. And of the tongue, the anterior 2/3 tongue is the mobile tongue or the oral tongue. So before we go on to this topic, we have to know what is this oropharynx. So oropharynx will be your base of tongue. This base immobile, base posterior 1/3 of the tongue, which has your palatine tonsils. Then which has your lingual tonsil. Then you have the palatine tonsils, uvula and soft palate along with the posterior and lateral pharyngeal wall. These together constitute this subsite of oropharynx. Okay, so when we are talking about the HPV associated oropharyngeal cancers, our area of interest is basically these two, the base of tongue and the palatine tonsils, because of the presence of tonsillar tissue in both these areas. Here the lingual tonsils and here you have the palatine tonsils. So what is the importance of this tonsillar tissue being present there? What makes it different from the rest of your oral cavity? So, as I said, now oropharynx is a separate subsite which is distinct from the rest of the oral cavity because of the presence of tonsillar tissue. And the tonsillar tissue, it's different from the rest of the oral cavity because it has that tonsillar crypt epithelium or the reticulated epithelium, which is so intimately associated with the lymphoid-based mucosa, so that we call it the lymphoepithelium. And viral-associated carcinomas are known to have this tropism for lymphoid-based mucosa, whether it is your EBV-associated nasopharyngeal carcinoma or this HPV-associated oropharyngeal cancers. So, Today we'll discuss a bit detail about the tonsillar crypt anatomy. Now, crypt, the word meaning itself is hidden. So you have a very fragile epithelium which is hidden or crypt. It is a cryptic epithelium within that dense lymphoid stroma. So what is the difference between a tonsillar crypt epithelium and the surface tonsillar epithelium? So the reticulated epithelium of the tonsillar crypt is thinner. It is fenestrated, second point, that is the basement membrane, where elsewhere when you have a stratified squamous epithelium lining the rest of your oral cavity, including the base of the tongue or your tonsillar surface, the crypt epithelium has a discontinuous basement membrane. So inherently there are holes or defects in the basement membrane. Third important point, it has intraepithelial capillaries. So if you see all these points, so compared to a thick stratified squamous epithelium, you are having a thin reticulated epithelium. The basement membrane is inherently discontinuous, or the basal cell layer is discontinuous, and you have intraepithelial capillaries. So vascular supply is there. So there is a natural barrier for tumor cell spread is absent in this crypt epithelium. So for comparing, this is the crypt epithelium compared to the normal squamous epithelium that you find elsewhere in the oral cavity. So see, it is thinner. You have this discontinuous basal cell layer through which the lymphoid cells, monocytes, all your immune cells can traffic into the epithelium. Whereas here you see a very rigid basal cell layer and then the spinosum, granulosum and the stratum corneum. So for a tumor to invade into the stroma in the rest of the oral cavity, it has to breach this basal layer, invade into the stroma and produce desmoplastic stromal reaction to become invasive. Whereas here, this is inherently having holes. So for a tumor arising in the crypt epithelium, there is no point in invading into the stroma and all. It is inherently having these gaps, okay, making it easier for tumor spread. Then, adjacent to this thin epithelium, you are having abundant lymphoid follicles, and this enables lymphocyte trafficking into the epithelium. You get a lot of intraepithelial lymphocytes and mononuclear cells. So what is the importance? These lymphoid-rich tissue are exposed to antigens present in the oropharynx, including your HPV antigen. So this is, and another thing that you have to remember about this reticulated epithelium is that they are basal appearing squamous cells embedded in the rich lymphoid stroma. So this, you don't have a gradation like basal, the spinosum, granulosum there. All the cells are basal appearing squamous cells. This is a schematic representation. You will get a better idea. This is the surface of the tonsil, and here when you reach the crypt, you can see that there are gaps or holes at the basal cell layer through which the lymphocytes, monocytes and other immune cells can traffic within the epithelium. The HPV virus, that antigen can react with these lymphocytes. So when you speak about high-risk HPV associated oropharyngeal carcinoma, from any point of view, whether it is epidemiology, clinical, pathophysiology, morphology, molecular, any aspect you take, it is different from conventional head and neck squamous cell carcinoma. That concept you have to understand it and apply it to understand this entity and why this is so much different and why there is so much hype about this high-risk HPV associated oropharyngeal carcinoma, in spite of the fact that it is a squamous cell carcinoma. So if we look into the demographics, these type of cancers are seen in younger age group. So traditionally, when you think of squamous cell carcinoma, oral cavity, buccal mucosa, alveolus, you have an older patient, 60s, in his 60s or 70s. Here you get a patient a decade or so younger than the classical age group. And risk factor, that is the most important thing. So conventionally, you think of oral cavity squamous cell carcinoma, immediately the risk factor that you ask your patient is how much cigarettes you smoke, do you chew pan, do you use any other tobacco products? So that is not the case in this. It is a sexual behavior that is contributing to this disease. That is the etiology. In fact, oral sex has been found to be the risk factor for this HPV associated oropharyngeal cancer. So when you elicit history from a patient, you have to keep this in mind from the clinical side. Also, this is a disease more commonly seen in developed countries. Because of these behavioral aspects, this disease is seen more in developed countries, but we also are beginning to see cases of this HPV associated cancer. And what about smoking? Does it have any role? Of course, it has a role in that it is a co-carcinogen. So the primary thing is that this disease is associated with sexual behavior, but if that patient is also a smoker, then that facilitates the progress of an HPV infection of the oropharynx into a cancer. Now, clinically, what do you expect? So, generally speaking, if you have a mobile tongue squamous cell carcinoma, the patient presents with a large primary, then only you get a lymph node mets. Okay, so it is in the higher stages of the disease that you see this large lymph nodes. But classically, the difference in this case is that usually the primary tumor is very small. So I have told that the tumor is seen in the tonsillar crypt. So it is cryptic. And surface, if you examine the patient, you won't be seeing any tumor. It is difficult to detect clinically tumors of the oropharynx because they arise in the crypt epithelium. The surface looks normal. Or maybe some dysymmetry in the size of the tonsils, some dysphagia. So non-specific symptoms are that with which the patient reports to you. So it is a small primary. So what is a classical presentation? The classical presentation is as carcinoma of unknown primary. Patients coming to you with large cystic lymph nodes of level 2, 3. That is a classical presentation. They are cystic, they are large, and usually seen in the upper and middle jugulo-digastric lymph nodes with unknown and as unknown primary. You have to go back when the patient comes with this clinical presentation and you elicit the history, then you go back and look, and maybe you will be lucky to detect the primary in a biopsy from the tonsil. But in spite of these presenting with the large cystic lymph nodes at initial presentation itself, these group of tumors have a very good overall survival. So it is 82% versus 57% as in the case of conventional squamous cell carcinomas. So that is it. And what is the difference in microscopy? So microscopy, the most common morphology is that of non-keratinizing. And you can get focal keratinization, but the classic morphology is non-keratinizing. And basaloid. So if you remember what I have told about the reticulated epithelium, these cells are generally basaloid cells. So that it is actually recapitulating that morphology. So you have this basaloid morphology. That is cells with scanty cytoplasm and ovoid bar spindle shaped. So relatively you get a monomorphic hyperchromatic appearance. So this is one of our cases wherein this was a tonsillar biopsy showing that it is actually a monotonous, you see blue cells, non-keratinizing, hyperchromatic. That is the appearance. Keratinization can be absent, is usually absent, but it can be focally present also. That doesn't rule out an HPV associated cancer. And there is frequent mitosis and apoptosis. So if you see the basal layers everywhere, there is more of mitosis and apoptosis at the basal layer. So here also in the cancer cells, there is frequent mitosis and apoptosis. Pomodonecrosis can be frequent, and there is permeation by lymphocytes. So that is a classic morphology of this HPV-associated oropharyngeal squamous cell carcinoma. So these are different pictures from our own cases. So this is a higher purview where you can appreciate that basaloid appearance, rather monotonous, hyperchromatic, high NC ratio, lymphocytes and apoptosis, mitosis. Okay, so this is still higher power. So sometimes they are such an appearance, you may have to do a immunophore squamous cell differentiation to confirm that this is squamous cell carcinoma, because they are so basaloid, no keratinization, and with this mitosis, apoptosis, sometimes you require immunos like your P40, P63 or CK5R6 to confirm that they are squamous cell carcinomas. So like the conventional squamous cell carcinoma, this entity also has different variants like lymphoepithelial, like the papillary, adenosquamous, the sarcomedoid and small cell. So all these variants can come in HPV associated carcinoma, but the small cell, as everywhere else, is associated with a bad prognosis. And now something about P16-IHC. We all are aware of this P16-IHC now. And P16 is used as a standalone test. That is a recommendation from either the CAP, the ASCO, the AJCC, the UICC. Everyone is of the opinion that P16 immunohistochemistry can be used as a standalone test in the diagnosis of this entity. Why so? When you recommend a test for universal application, you have to take into consideration so many elements. It is not that it is the gold standard, but you have to take into consideration its availability, the economic point of view. Is it cheap enough so that it can be applied worldwide? Okay, is the facility available? So considering all those points, P16 can be used as a standalone test, though it is just a surrogate marker. You are not directly demonstrating HPV with this P16-IHC. And they have put, the AJCC as well as the CAP has come with strict criteria in the interpretation of this P16-IHC. There should be diffuse nuclear and cytoplasmic positivity of more than 70%. So focal positivity is a no, it is not taken as positive. Nuclear alone, cytoplasmic alone, no. So it has to be diffuse nuclear and cytoplasmic positivity of more than 70%. In fact, the AJCC has a still higher criteria of 75%. So 70, 75, that is it. And usually when you do a P16, you get a diffuse nice positivity of nuclear and cytoplasmic stain. Then what are the molecular tests for HPV that is available? You have the in situ hybridization of DNA and RNA in situ hybridization is available. PCR test is available. The NGS is also there, wherein you can subtype the type of HPV. Subtype of HPV is possible with the next generation sequencing. So to briefly, this is a very simple and easy to understand representation of how the HPV infects the cell and how we use P16-IHC for its diagnosis. This is from the American Journal of Surgical Pathology by Bishop et al. So here the HPV enters the host cell, the double-stranded DNA is getting integrated into the host DNA. So the viral integration happens here. The next step is transcription, wherein the mRNA E6 and E7 mRNA are formed. Next is translation, where the E6 protein and E7 protein are formed. And E6 binds with the P53. So the P53 is inactivated here, so there is tumor suppressor inactivation happening here. And what does E7 do? E7 binds with the retinoblastoma protein. So when it binds with retinoblastoma protein, there is aberrant overexpression of B16 because the retinoblastoma protein that is getting blocked, and you get B16 overexpression, which is what we detect by our immunohistochemistry. So at these different levels, you can detect the HPV, like here you can detect the DNA in situ hybridization, this mRNA, you can find the RNA in situ hybridization, of course. This is more sensitive than the other tests for detecting HPV. So next, this is the IHC pictures. From this you can understand, see the surface epithelium, this pale staining that you see is not a positivity. It is in the crypt epithelium that this carcinoma arises, and see the nice diffuse nuclear and cytoplasmic staining. The higher view, this is from our case. So P16 nuclear and cytoplasmic diffuse staining more than 70%. Now, since I have mentioned how this P16 IHC helps in the diagnosis, let me once again tell that P16 is sensitive. The sensitivity is 94%, more than 90% in most of the studies, but it is not specific. It can be, the P16 overexpression can be due to many other factors other than this HPV. So this interpretation of P16 has to be very careful and done when there is the appropriate background. You have to correlate with the clinical, what you see under the microscope, and then decide on your P16 and then interpret it. And several studies have shown that about 8 to 33% of P16 positive cases can show negative result with molecular, HPV molecular when you do. This can be due to technical issues and also due to the fact that the positivity, P16 positivity which you demonstrated would have been independent of HPV gene expression. It could have been due to some other causes. So a guideline towards when you have to supplement your P16 IHC with a molecular testing. So as I said, classically you expect this HPV carcinomas to be non-keratinizing or predominantly non-keratinizing. So in that case, if you get a P16, a strong, like 2 to 3 intensity score and more than 70-75% diffuse cytoplasmic and nuclear stain, then there's no requirement to confirm it with molecular. Similarly, if it is a keratinizing, you don't expect that HPV squamous cell carcinomas to be that keratinizing. So when it is keratinizing and the P16, you somehow did a P16 and it is negative, then also there is no need to do a HPV molecular testing further. But then when there is discordance, like you are expecting in a non-keratinizing to be HPV positive, but your P16 is negative, then it is useful to supplement it with a molecular testing of HPV. Similarly, a keratinizing squamous cell, you are not expecting a P16 positive, but somehow your IHC gave you a nice strong P16 positivity. Then also it is better to do a HPV molecular testing. So this is HPV in situ hybridization. All these black dots show the positivity. Now, several studies have compared had studied the prognosis with these HPV molecular and P16 pattern. So they say that when you have a P16 positive along with a molecular positivity for HPV, that group of patients have the best prognosis. If it is P16 positive but the molecular HPV testing is negative, those group of patients have intermediate prognosis. And the worst scenario is when patient has HPV molecular test positive with P16 negative or both negative. So those patients are having worse prognosis. And of course, more than 90% of the oropharyngeal squamous cell carcinoma which are HPV related is caused by high-risk HPV type 16. And HPV 33 and 35 about 2 to 3%, and HPV 18 is even less than 1%. better prognosis than N2. So to avoid that ambiguity, HACC has taken out this PN3 from this P16 positive HPV associated oropharyngeal carcinomas. And also clinically also it is different. You have a 6 centimeter node still being classified as N1. Okay, and N2 is still 6 with contralateral or bilateral, and when it is larger than 6, it becomes N3. So that is the difference in the N staging of this group of tumors. And mind you, there is no need to comment on extranodal extension. In fact, we pathologists will rarely only come across such a scenario because these tumors are so radiosensitive. Most instances, the patients will be given radiotherapy or chemotherapy. So it is highly unlikely that you will get a nodal dissection to report on in the case of P16 positive oropharyngeal squamous cell carcinomas. So a talk on this topic will not be complete without mention about carcinoma of unknown primary or TUP. Because I have already mentioned, this is the symptom, or this is the classical clinical presentation with which the patients present. So, because of this, because of our knowledge of HPV associated oropharyngeal cancer, there has been dramatic change in the approach in the diagnosis of cervical nodal metastasis of unknown primary, because HPV positive oropharyngeal cancer are known to present as large, bulky metastatic cervical nodes with occult primary in the oropharynx, and you are supposed to do P16 IHC or molecular tests for HPV in those cervical nodes. Sometimes after you do this, then the clinician goes back, and if they are lucky in a biopsy, they'll pick up this primary tumors. So this is as I said, this is the level 2 and level 3, the upper and middle gynodigastric nodes, which are the common sites of presentation of this nodal metastasis. And it is a recommendation from CAP that HPV is preserved in the metastatic sites, and so demonstration of HPV in the cytologies from cervical lymph nodes strongly raises the possibility for an oropharyngeal primary tumor. But I would like to add a word of caution. So suppose you get a patient has carcinoma of unknown primary, you find that it is a non-keratinizing squamous cell carcinoma mets and positive for P16, okay, well and good. But that immunoreactivity for P16 should be interpreted with caution. That is because 20% of metastatic skin. So suppose you have a skin tumor in the head and neck region, skin squamous cell carcinoma, or we very well know that lung squamous cell carcinoma can also present with cervical lymph node mets. These have absolutely no association with high risk HPV, but they are known, and it has been proven that they can show 70% of nuclear and cytoplasmic positive staining with P16. So P16 positivity alone does not equate with HPV positive oropharyngeal squamous cell carcinoma. So that you have to take that message home. It is you have to get the appropriate background. You have to thoroughly examine the patient from the clinical side and rule out a primary, and you have to rule out a primary elsewhere before considering that this could be P16 positivity due to this HPV associated oropharyngeal squamous cell carcinoma. And it is well and good if you get a biopsy later on from the tonsil and you are able to prove that primary HPV associated oropharyngeal cancer. And also one of the closest mimic of a cystic metastatic squamous cell carcinoma in the cervical region is a pharyngeal cleft cyst. So some studies have shown that even pharyngeal cleft cyst, this P16 can take up in those cases also. So it's highly non-specific. Though being a sensitive test, it is non-specific, and it has to be judiciously used and interpreted. Now, what are the challenges? Now that we have known this entity, What are the challenges associated with this HPV associated oropharyngeal squamous cell carcinoma? So the clinical significance is widespread, right from prevention to the prognostication. So prevention now, instead of the smoking and the traditional risk factors, you have to educate your patients regarding that this carcinoma is arising because of your sexual behavior. You have to educate to prevent this disease. Then diagnosis is also difficult. Any other subsite, the specificity in sites other than the oropharynx, and so it's not recommended to just for so that temptations also should be not
Yes,
good for us.
yes.
Yeah. Yes.
Misuse and overuse can really lead to
Yeah.
confusion.
Yeah.
And what you rightly said was in the cervical lymph node met, when you are using P16, one has to be extremely careful.
Yes.
Thank you so much, ma'am. Wonderful presentation. We would like to have you here again. It's something else, maybe thyroid, right?
Yeah, sure.
Request you to share the PDF of your presentation, so we will upload it for the students on our site.
Okay, fine. Thank you.
Take care. Good night.
Thank you. Good night.